Hello everyone. So today we will be discussing the topic Puerperium. Okay, this is very important topic as far as our exam are related. 1 to 2 question come in every exam. Okay, so we have covered the postpartum contraception in the contraception lecture. Okay, so now we will discuss the rest of the Puerperium changes. It will also include the breastfeeding and the lactational amenorrhea. Please focus at least 1 or 2 questions quite often come. Okay, you will see in NEET PG 22 two questions have come. Okay. So this is a question from NEET PG 22. On the second postnatal day, where would the fundus of the uterus would be? Okay, so they are asking about us about the involution of the uterus. Okay, just after the third stage of the labor, the uterus come once the uterus is contracted after the placental removal, uterus is just below the umbilicus. Okay, so every point is important. It has been asked in NEET PG 22. So in FMG and NEET PG, the questions can be asked. So do focus. After the third stage, it is just below the umbilicus. It slowly decrease in the size now. Okay, so you all know in a normal female, we can't feel the uterus. We feel it only on the PV, right? So now after the third stage it is below the umbilicus, and slowly it goes down, to which we say involution of the uterus. Okay, and the speed with which the uterus goes down is 1.2 centimeter per day, 1.25 centimeter per day, or you can say one finger per day. So here the question was asked, on the second postnatal day, where would be the fundus of the uterus would be. So if we see, this is the lady umbilicus, and just after the delivery it is like this, below the umbilicus. Uterus is below the umbilicus. Every single day it goes down with the speed of 1.25 centimeter or one finger. Okay, so on the second postnatal day, it will be 2 finger below the umbilicus. So the answer is the second option, 2 finger below the umbilicus. Okay, now let me tell you, by 2 weeks, if we say specifically after 10 to 14 days, okay, it is a pelvic organ. So it is not palpable on abdomen, it is a pelvic organ. Its clinical significance is that because now the uterus has gone into the pelvis, it is not felt on abdomen, so now we cannot do the postpartum tubectomy after this. Okay, you must be knowing that postpartum laparoscopic tubectomy is contraindicated. We only do the mini lap or laparotomy, tubectomy, and that also is done up till 7 to 10 days, because at that time the uterus is a pelvic organ and fallopian tube can be felt easily. After that it is not done. It is done after 6 weeks. Okay, and uterus completely involutes or goes back to its normal position after 6 weeks. Okay, completely involution takes 6 weeks. By 2 weeks it's a pelvic organ and it is not felt on per abdomen. All these points, once again I'm telling you, are very important. Now why this uterus involute? What is decreasing the size of the uterus? So the withdrawal of estrogen and progesterone just after the delivery, it activates the collagenases and the proteolysis enzyme. So these two enzymes, they reduce the size of the myoepithelial cells. In addition to this, oxytocin, which is released at the time of the lactation, it contracts the uterus. So the uterus remains contracted, and this collagenesis and proteolysis, which are released due to the withdrawal of estrogen and progesterone, reduce the size of the myoepithelial cells. So these three hormones are responsible for the involution of the uterus, and this oxytocin, which is released at the time of the lactation, it acts on the uterus, and it contracts the uterus and also cause the pain after the delivery. So this pain, which is felt especially during the lactation and after the delivery, is known as the after pains. Okay, so after pains, they are more prominent in multigravida, because multigravid uterus, as you have seen, it has a tendency to get atonic. So again, the uterus gets contracted. We have studied in PPH that multigravida uterus has a tendency toward atonicity. So once again the uterus get atonic, then again the oxytocin contracts the uterus back to its size, and the patient suffers pain. And these after pains, they are only intense in first 3 days. Okay, subinvolution means that uterus is not going back to its normal size. It can be due to retained bits. Already discussed in PPH, retained bits, it leads to atonicity, and then it leads to relaxation of the uterus. Infection also interfere with the involution and with the release of the collagenesis and the proteolysis enzymes. Distended uterus, as seen in polyhydramnios case, multiparity in the multiparity, polyhydramnios, and multiple pregnancy also leads to the slow involution, not at the normal speed. Okay. So this was about the involution of the uterus. Let's see the next question. The reason of abdominal pain when the mother is breastfeeding her baby or after pains is oxytocin. Okay, already explained. A woman delivers a healthy baby. She gives exclusive breastfeeding to her baby as is required for the first 6 months after the delivery. She presents to the OPD with amenorrhea. Etiology of the amenorrhea is the hyperprolactinemia. So why prolactin is released? As you all know that when a fetus lactates from its mother, then the oxytocin and prolactin, these two hormones are released. Okay, the prolactin, which is released, it suppresses the hypothalamus release of gonadotropin releasing hormone, and thereby it suppresses the HPO axis. Needless to say that when GnRH will not be released, then FSH-LH will not be released. When FSH-LH will not be released, then estrogen and progesterone will not be released. When there will be no estrogen and progesterone, then there will be no periods. Okay, so the prolactin, which is released during the lactation, it suppresses the HPO axis by stopping the release of gonadotropin releasing hormone. This suppression is not a constant suppression, it is only during the lactation. So the lady who is lactating more or who is giving the exclusive breastfeeding will have a prolonged amenorrhea. If due to any reason the lady is not lactating, then the lady periods will come soon. Okay, so it is quite often asked in your exam that why there is amenorrhea after the delivery, and they don't tell. In this question they have told that the baby is lactating, and usually in the questions they don't tell that the lady is lactating, and it is normal that a lady lactates, and it is perfectly normal finding, so one has to rely on the fact. Let's see, this is FMG August 20 question. A patient presented with secondary amenorrhea 3 months post delivery. Before surgical intervention is considered, which of the following can be done? Answer to this is assurance, because you know that you can see in this question they have not written that the lady is lactating. It's quite normal thing that the lady lactates. So it is abnormal that a lady does not lactate, right? So you have to assume that there is a amenorrhea due to hyperprolactinemia or increased prolactin secretion. Lactation, let's see the lactation. First of all, three terms are related to lactation. What is mammogenesis? Is the synthesis of the mammary glands for lactation. Estrogen is responsible for the duct's proliferation, and progesterone is responsible for the alveolar proliferation of the mammary glands. Okay, how milk is secreted is known as lactogenesis. Okay, the prolactin level they fall just after the delivery. Okay, estrogen and progesterone prolactin levels are at a high value in the late pregnancy, but they fall just after the delivery. And the estrogen and progesterone which withdrawal which occur after the delivery, it inhibits the release of prolactin inhibiting substance, and then that again rise the prolactin. Okay, now this prolactin is mainly responsible for lactogenesis or milk secretion. Okay, lactogenesis means milk secretion. Lacto means milk and genesis means banna, synthesis. So milk secretion is due to prolactin, and its release is due to the estrogen and progesterone withdrawal. So the main hormone which is leading to the lactogenesis is estrogen and progesterone withdrawal. Okay, so lactokinesis, now the milk has been synthesized, now milk has to come out. Okay, milk has not got any wheels so that it can come out. The ducts have the muscle cells or myoepithelial cells, they get contracted due to the oxytocin. Okay, and now that secreted milk is come out, we say release of the milk or let down of the milk due to the oxytocin. Okay, so now you have seen that the estrogen and progesterone withdrawal or release, what does do? It inhibits the release of prolactin inhibiting substance. Okay, so when there will be increase in the progesterone and estrogen, then there will be decrease in the milk secretion, and that prolactin inhibiting substance is nothing but dopamine. So whenever we want milk suppression in the case of IUD, and the couple who gives their child to other couple for adoption, then cabergoline and bromocriptine is used. Okay, and if we want to increase the milk secretion, then dopamine antagonist metoclopramide is given. Okay, now this is FMG December 2019 question. Breastfeeding should be continued at least for how many months? Answer is 6 months. And I said July 21 question. Lactation woman needs more compared to the pregnant woman. Answer to this is vitamin A, because vitamin A during the pregnancy it leads to toxicity. Okay, so but after the delivery, the lady needs more vitamin A as compared to the pregnancy. Absolute contraindications of breastfeeding. Now what are the absolute contraindications of the breastfeeding? You are going to focus here in HCV, HSV, HIV, CMV, no viral infection. This breastfeeding is contraindicated. The conditions in which the breastfeeding is contraindicated are if the female or the mother is having any substance abuse, especially cocaine, alcohol, then the female is not allowed to breastfeed. Then next is the galactosemia, because to the baby in this there is lactose intolerance. And third is if the mother is taking any cytotoxic or anti-cancer drug. And last but not the least, if the mother is on lithium, because it causes the anomaly in the child. If the child gets lithium in the milk, then it causes anomaly in the child. So lithium, mother on the lithium treatment is contraindicated for the breastfeeding. And so we also have one doubt about the warfarin. In warfarin, the lactation is not contraindicated, because warfarin only affects the organogenesis, and so warfarin is contraindicated only in the first 3 months of the pregnancy, but in the lactation it is totally safe. Questions are asked on this point. So the answer to this question is, of course, galactosemia. In HCV, HSV, CMV, and HIV also, it is not contraindicated. Nursing mom presents with fever and breast tenderness after 2 weeks postpartum. Now there is breast tenderness. It means mastitis case is it. Which oral antibiotic is best for her condition? Answer is flucloxacillin. I just want to tell you that beta-lactamase resistant drugs are used, and out of these it is a flucloxacillin. Okay, you better know about pharma than me. Next question is primipara presents 14 days after giving the birth with fluctuating breast swelling on her left breast and fever. All are true except. So as already studied, we are not going to stop lactation in the case of breast abscess. Some students have a confusion in their mind that from the breast which is having abscess we can stop the feed. No, the lady with breast abscess can give the feed from both the breast. Okay, so first of all, the correct answer is stop lactation. No, lactation is not stopped. So here I want to tell you that needle aspiration and antibiotic are done for the abscess which are less than 5 centimeter, because they are less invasive and less troublesome, and the IND is done for more than 5 centimeters. So all are done except stoppage of lactation. Now first line, treatment of lactation breast abscess. In the case of breast abscesses, so as already told, first line we have to try, because this is less cumbersome, ultrasound guided percutaneous aspiration and antibiotics. So this is the first line treatment of abscess. Once there is abscess, then we have to drain the abscess, and we prefer to drain it by ultrasound guided percutaneous aspiration, because it is less cumbersome. Okay, IND is done only if the abscess is more than 5 centimeter, and antibiotic are given in the case of mastitis, not in the case of the abscess. Treatment in puerperal pyrexia. What is puerperal pyrexia? Puerperal pyrexia is, temperature in puerperal pyrexia. What is puerperal pyrexia? Let's see. Just after the delivery for 12 hours, the temperature rises a little. It's normal. Also after 24 hours after delivery, if the temperature rises, because in the first 12 hours the temperature rises normal, so one has to exclude those first 12 hours. In extra we have excluded 12 more hours. So if the temperature is rise after 24 hours of the delivery, then it is not physiological, then it is abnormal, it is a sepsis. Okay, and the temperature should be rise more than 100.4. 98 wala figure is not considered, because a small rise is seen in the case of breast engorgement. So 100.4 is the temperature above which we will say that pyrexia is there, and we have to exclude the first 24 hours of the delivery. Okay, the most common bacteria which causes the puerperal pyrexia is streptococcus. The most common bacteria which cause the lactational abscess is Staph aureus, okay, or Staph epidermidis, okay. And if they ask you what are the antibiotics given for the puerperal pyrexis, of course you should cover the positive and the negative both, okay. Endometritis is the most common cause of puerperal infection and or pyrexia. So genital infections are caused there, and anemia worsens that pyrexia, and prolonged labor and prone the patient to the puerperal pyrexia. The most common reason is always is endometritis, genital infection, okay, or you can say mishandling. So the answer to this question is 100.4. 100.4. Okay. Let's see this question. 22 years female post cesarean, post LSCS admitted to ICU with complaints of pain, lower abdomen, and 102 degree Fahrenheit. So this is a case of puerperal pyrexia. She was started on IV antibiotic. After 5 days antibiotic, she started looking back better, but fever does not subside. So even after antibiotic, if it is not subsiding, then it is something more than the puerperal sepsis. So this is a case of septic pelvic thrombophlebitis. Okay. So now here we have also to give the heparin or warfarin, you can say. So the answer to this is continue, because it's a case of septic pelvic thrombophlebitis. So we have to continue the antibiotic. So the answer is continue IV antibiotic and add heparin. We can add warfarin also, but we are not adding because it's because here with warfarin the option was stop IV antibiotic. We are not going to stop IV antibiotic. Patient present with green vaginal discharge 5 days after the delivery in early puerperium. So green vaginal discharge 5 days after delivery indicates something suspicious, infectious. Next line of management is, of course, per vaginal examination. We are going to examine whether that discharge is having malodor or not per vaginal examination. Now we will learn about the postpartum psychiatric disorder. 28 years woman is on her third postnatal day. A psychiatric opinion is sought in view of occasional crying in episodes, fatigue and lack of sleep. What is the likely diagnosis? So let us see about the postpartum psychosis problems. So first of all, you know that just after the delivery there is estrogen progesterone withdrawal. This withdrawal leads to the postpartum blues. Okay, mnemonic for it is BPD. So why there is blues? Due to the withdrawal of the estrogen and progesterone. In this we need to give assurance to the patient, and patient soon gets okay in a week, and it is seen in the first 7 to 10 days. What is postpartum psychosis? Postpartum psychosis is very acute in onset. Patient does a psychotic behavior. It is seen after 10 days, and antipsychotics are the drugs. So first blues come, it is B. P is for psychosis, and down is for depression. Depression comes, postpartum depression is after 6 months. It is gradual in onset, and fluoxetine are the drug of choice if there is postpartum depression, and the reason behind this alteration of the hormones due to the HPO axis. Okay. Now we will do the last topic, the sequence of lochia. Lochia is a decidual secretions which are released after the delivery per vaginally, and you need to remember this. What is the order? It is Ram, Sita, Amar. Rubra is the red secretions just after the delivery, and it is up till 4 days. is, and serosa is the serous discharge, and it is from 4 to 8 days, and alba is the white discharge, and it is up to 8 to 16 days. This 16 days discharge is known as lochia, and the sequence is quite asked in exam: rubra, serosa, and alba. Rubra, red discharge is due to the RBCs, and white discharge alba is due to the WBCs, and it can prolong. It is normal if the discharge prolong up to 25 days. It is quite normal, no abnormality is there. But if rubra phase prolong, then it is abnormal, then it is indicates subinvolution. Okay, something suspicious. If rubra phase prolong more than 4 days, okay, it indicates that there are retained bits and there is extra bleeding. Okay, then next is question. Answer to this question is, the sequence of lochia is rubra, serosa, and alba. Okay, next question is, cardiac output returns back to normal after how many days of delivery? The answer to this is 10 days, and this is checked from the Williams. Again, I'm telling you, let's see what are the other parameters and how they return. The blood volume return back to normal in 1 week. The cardiac output returns back to normal in 10 days. Fibrinogen level return back to normal in 2 weeks. And GFR return back to normal in 2 weeks. Okay. So these are the parameters. When they returns, they can to be asked in our exam. So just focus on this too. So that was all about the Puerperium. Thank you and have a nice day.